Hello, my name's Scott Hackett. I'm a paediatric immunologist from Birmingham Heartlands Hospital, and I might know a number of you. I've met you on the HAE UK patient days previously. I'm sorry we're unable to have a face-to-face patient day this year, but I'm very grateful for Laura and Rachel asking me to talk to you on paediatric issues on what is the 10th anniversary of HAE UK. I'm going to briefly cover four areas. The first is going to be, when can you test your children to see if they've got HAE? The second is going to be, when do children generally develop symptoms, and are those symptoms the same as adults or are they different? The third is how to treat children. Is that the same as adults with HAE or is it different? And the fourth is going to be the future of HAE. So I suppose one of the questions that the majority of parents and families ask me is, when should I get my child tested to see if they've got hereditary angioedema? Because of course in the majority of patients there's a 50% chance that they will have inherited this condition. So if you're a parent and one of you has hereditary angioedema and your partner, the wife, is pregnant, when would you get that child tested? Would you get that immediately at birth from blood from cord blood in the first 6 months of life, in the second 6 months of life, between 1 and 2 years of age, or would you leave it until the child is symptomatic? I don't think there's a right and a wrong answer for most parents, and in fact there isn't a right and a wrong answer really. I would suggest that people are tested before they become symptomatic if possible, but I'll talk about when children most likely or most frequently develop symptoms. But generally I recommend that children are tested before their first birthday, but not immediately at birth because it can be difficult. Also, cord blood can lead to erroneous results. In some centres where genetics are performed, and in fact in my centre it's very rare that we perform any genetics on the SERPIN gene, so we can't actually do any genetic testing, and people can do genetic testing from birth. But what I recommend is that all children before their first birthday should, if at all possible, have a C4 measured and a C1 inhibitor level measured, and depending on what the parents' type of HAE is, whether it's type 1 or type 2, they should probably also have function done. In fact, in the majority of patients I try to do function. So when do children develop symptoms of hereditary angioedema? Parents often ask if they present early, do they get more severe disease? There is some data in poster form that this might be the case, but it's still uncommon for children that present early to get severe symptoms. In fact, the majority of children don't present early in life. And can children present for the first time with severe episodes without any preceding episodes? That can occur, but again, it's rare. It does depend on, to some extent, where you live, and the data from America and Germany is different to the data that we tend to see in children in the UK. In America and Germany, children seem to be getting symptoms earlier in life than they are in the UK. In the UK and in their Birmingham cohort, generally, it's rare for children to get any symptoms before the age of 2, but they can. And the majority of children develop symptoms between 4 to 8 years of age. There were a number of our patients up to the age of 18 that had absolutely no symptoms despite having hereditary angioedema confirmed on testing. What symptoms do children get when they get hereditary angioedema? They tend to get the same symptoms as adults, although severe attacks are rarer, particularly in the under 10s. Children tend to get a lot more abdominal symptoms, and this can be really quite difficult to elucidate from, is the child just complaining of diarrhea and vomiting, or is there anything really wrong with them, or is this a true HAE episode? They get a lot of peripheral swellings, as you'd expect, from trauma. And they tend to get more problems as they start to go through puberty, particularly the female, particularly young ladies. The symptoms that children get also follow the same pattern as in adults, in that they're usually a slow rise in symptoms over a few hours to a day, last for a few days, and then settle over a day. So they're not the acute symptoms that we'll see in patients that are often labelled as allergic. How should children with hereditary angioedema be treated, and should they be treated any differently to adults? In the majority of children with hereditary angioedema, they don't have significant symptoms, but they can, and treating can be very difficult. A number of patients don't have any treatment for peripheral attacks and for abdominal attacks. And whilst I think that is okay for adults, because they can make that choice, their decision and choice themselves, I don't think that's appropriate for children, particularly if it's causing lots of distress. Unfortunately, all of the treatments that are useful for children, and I'm not including tranexamic acid here, mean that they need to have an injection, which of course can exacerbate symptoms and cause significant worry and concern in the families and also between the health professionals. In a few patients, tranexamic acid works very well, but this is probably less than 10%. And at best, I think it takes off the worst of the symptoms rather than ameliorating all the symptoms. So I know a number of patients use this for peripheral attacks and for abdominal attacks. If we could give treatment that's easy to give and is simple and has no side effects, then we would use it for all, including peripheral attacks. And in fact, children and young adults where we've persuaded them to use an injectable method, they've realised how much easier it is to control their symptoms and how quickly their symptoms disappear away. But I understand why parents don't always want to put their children through this, particularly if they need cannulation. With the advent of icatibant and the fact that we can now administer this into small age groups, it's very easy to teach parents and indeed young adults how to administer medication to themselves. Even if the attacks are infrequent, there's not a lot to learn, so they don't forget how to administer icatibant compared to having to cannulate or put a butterfly into someone's vein and then administer a C1 esterase inhibitor concentrate, although both are available and both are probably equally as effective in children. Other medications for children, lanadelumab is the monoclonal antibody against bradykinins that's available and is now licensed for children, although in the majority of children that I see, none of them would fulfill criteria for the use of lanadelumab. In the future, new bradykinin inhibitors, oral bradykinin inhibitors, are coming online, either as prophylaxis or as treatments, and these would be extremely welcomed for patients with hereditary angioedema. The importance of how to treat patients with hereditary angioedema and in paediatric populations is that we need to know the diagnosis. So even if your child hasn't had a formal diagnosis but presents with hereditary angioedema symptoms, we have to explain to medical professionals that there's a 50-50 chance that they would have that disease. And indeed, I know from families a lot of people are completely ignored, but that does need to be pushed through. So speaking to your immunologist to have a letter to take along if there are any problems. But any children that develop any symptoms, they should all have a treatment letter, a treatment passport letter of how to manage those episodes, which would include C1 esterase inhibitor concentrate and or icatibant and other treatments if they become very severe and unwell. It should also detail the fact that anaesthesia shouldn't be delayed if it's required just because the patient has got hereditary angioedema. Of course, they can have anaesthesia with C1 esterase concentrate cover if needed. So in summary, hereditary angioedema should be diagnosed in all children, probably around or just before their first birthday. Symptoms in children are very similar to in adults, although it's rare for children to get severe symptoms before the age of 10. Treatments are available for all children, but they're not ideal at the present, but there are new treatments that are coming, and I look forward to managing children in the next number of years with new medications that would hopefully make their lifestyle better. Thank you very much. If you have any questions, please join us for our live Q&A session this afternoon on the 21st of November.